everybody, welcome to Dr. Ghost YouTube channel. Prepping PG entrance one topic at a time. Please like, share and subscribe. Hope you enjoy.
Hello guys, today we'll talk about IHD, which stands for ischemic heart disease. So what do you mean by ischemia? As we all know, ischemia means that there is a reduced blood supply to an organ or a tissue. In these cases, that is in ischemic heart disease, the reduced blood supply is due to a plaque buildup within the blood vessels. Okay, so now ischemic heart disease can be divided into two parts, that is a stable ischemic heart disease and an acute coronary syndrome. First, we'll talk about stable ischemic heart disease. So what happens in stable ischemic heart disease? Stable ischemic heart disease is also known as stable angina or angina pectoris. Okay, so what happens here is that there is a chest pain on exertion, on pain that lasts for less than 10 minutes and it subsides on rest and nitrates. Okay, if the patient was prescribed nitrates beforehand for angina, then it will also subside on nitrates. Otherwise, most of the times in less than 10 minutes, the duration is very important. In less than 10 minutes, the pain subsides on rest. Okay, so what's the difference between stable ISD and acute coronary syndrome when it comes to plaque? I'll explain you on the sides. What happens in a blood vessel is that this is a normal artery. Here the lumen is normal. What happens due to excess of cholesterol in our body or excess intake of cholesterol, there is a plaque buildup in our blood vessels which narrows the blood vessels. Okay, plaque buildup inside a blood vessel, the blood supply is just enough to meet the requirement of the tissue at the rest. When the body is in exertion, okay, when the heart is in exertion, like we are doing exercise or we are running or we are doing some heavy work, the blood supply, the myocardium needs an extra blood supply to work more. Okay, in these cases the lumen of the blood vessel, which was narrowed due to plaque present in the blood vessel, is not enough to meet the supply of the myocardium. So that's why there is a pain in the chest, and as soon as we rest, there the demand of the myocardium decreases and hence the pain subsides. Also the nitrates are vasodilators, so they dilate the blood vessel and increase the blood supply. So on taking nitrates also the pain subsides. Now what happens once a plaque is formed? Now the plaque grows and ruptures. Okay, the plaque grows and ruptures. In these cases what happens is, when a plaque grows, the platelet comes over it and subsequently the clot come over it and they block the blood vessels furthermore. This is a scenario in acute coronary syndrome. There is a rupture of plaque in acute coronary syndrome. Okay, and hence when the plaque ruptures, there is a formation of clot over it and the vessel lumen narrows further, and then the chest pain becomes prominent at rest also. Okay, so I explained you how in acute coronary syndrome there is a plaque has ruptured and hence there will be formation of clot over it, and thereby the chest pain will be present at rest and the pain will last for more than 10 minutes or 20 minutes. Okay, in acute coronary syndrome. Now we'll talk about acute coronary syndrome in subsequent slides. First let's completely talk about the stable ISD. Okay, now, stable ISD, also known as stable angina or angina pectoris, has a chest pain which on exertion which lasts for 10 minutes and subside on rest and nitrates. And also another important point is there is a chronic history of stable ISD. That is, there will be angina pectoris for a long term. That, like when patient does an exertional work, there will be pain. There will be a chronic history of this. Okay, of stable ISD. Now, how do we treat a patient with stable ISD? Okay, so the treatment involves mainly the use of nitrates. So nitrates are vasodilators. They increase the width of blood vessels and increase the blood supply to the myocardium when in need. Okay, this is how nitrates work. Also, we can prescribe beta blockers plus minus CCBs. Why these two are needed? Because they decrease the work of myocardium. Okay, now there is a new drug also, ranolazine, which is used these days. Also, ivabradine is used. One of the main drugs which is used in these conditions is aspirin, 75 mg per day, because I told you there is a formation of plaque inside the blood vessel and this will prevent that platelet clot formation over the plaque. Okay, and this because aspirin is an antiplatelet drug. Also the plaque is formed of excess cholesterol in our body, so we prescribe statins also for to reduce the cholesterol in our body. So the main treatment involves the use of nitrates as vasodilators, beta blockers for and decreasing the work of myocardium. There are new drugs like ranolazine and ivabradine, and also the two important drugs which has to be continued is aspirin 75 mg per day and statins. Okay, statins is a HMG-CoA reductase inhibitor, okay, which helps in reducing cholesterol. Also, now we have given these all drugs. Despite this medication, the patient complains that there is continuous angina present. Okay, there is continuous chest pain. Then we have to do a procedure known as PTCA, which stands for percutaneous transluminal coronary angiography, where we put a stent in the blood vessel, in the coronary vessel, and also we can do CABG. Okay, CABG is a coronary bypass graft. Okay, now since we have talked about stable ISD, we'll talk about another spectrum of ischemic heart disease, that is acute coronary syndrome. So what will be the characteristic features in acute coronary syndrome? The pain will be pain at rest will be present. In stable ISD, I told you, as soon as the patient takes rest, the pain subsides. But in acute coronary syndrome, there will be pain at rest. Pain, by pain I mean chest pain. Okay, and the pain will last for more than 20 minutes. I told you in stable ISD, the pain will last for less than 10 minutes. So what's the difference between stable ISD and acute coronary syndrome anatomically. So the major event which causes acute coronary syndrome is that the plaque which was present in stable ISD also, but here the plaque ruptures, and when the plaque ruptures, there comes platelets and clotting factors over it, and they further narrow down the lumen of the blood vessel. Okay, so when the plaque ruptures, the platelets get a surface to form platelet plug, and thereafter clotting factors come and form a clot. This narrows down the lumen further. So what happens? There can be a partial occlusion of the blood vessels. Okay, in case there is partial occlusion, then this is known as unstable angina or NSTEMI. NSTEMI stands for non-ST elevated myocardial infarction. But what if there is a complete occlusion of the blood vessel and there is no blood supply to the myocardium? Okay, then the part which was getting the blood, then the part which is blocked. So in case of complete occlusion, the part which was supplied by this blood vessel which has completely occluded, that part gets in cases of complete occlusion, the part of myocardium which is deprived of blood gets a transmural infarction. Okay, transmural means from endocardium to epicardium, everything gets infarcted, and in such cases we get a ST elevated myocardial infarction. There will be ST elevation in ECG. Okay, and now first we'll talk about unstable angina and non-ST elevated myocardial infarction. We'll get to STEMI later. Okay, now what happens in unstable angina? Say there is ST segment depression. Also in NSTEMI also there is non-ST elevated myocardial infarction, so ST segment gets depressed, so ST segment depression will be present in the ECG in both unstable angina and NSTEMI. Okay, now how to differentiate the unstable angina from NSTEMI? Also one more point, that in NSTEMI there is no transmural infarction, that some part of the wall gets infarcted but transmural infarction is not present, and that's the reason of ST segment depression. We will learn this when we go in details of ECG. Okay, but just remember that in STEMI there is transmural infarction of the myocardium, but in NSTEMI there will be part of the myocardium which gets infarcted. There will not be any transmural infarction, and ECG will show ST segment depression in both unstable angina and NSTEMI. Okay, now this both unstable angina and NSTEMI will be characterized by pain at rest and pain for more than 20 minutes. I told you these are the features of acute coronary syndrome also. Now how to differentiate between unstable angina and NSTEMI? Okay, we can differentiate it on the basis of a test called troponin test. We can use troponin T or troponin I. When we do the troponin test, if it comes out to be positive, it means there is an infarction, little bit of infarction, so we'll categorize it as myocardial infarction, and it will come under the category of NSTEMI because there is ST depression. But if the troponin in the blood is negative, then it will be known as unstable angina. Now one extra point is there, nowadays there are highly sensitive troponins used for the test, so even a minor amount of troponin rise will be detected by these tests. So what happens in cases of high sensitive troponin, if we are using to test, then the test always comes out to be positive because minute quantity of troponins can be detected, and hence the concept of unstable angina is slowly going out of the books because high sensitive troponins can always be detected in the blood in case there is a partial occlusion of the blood vessel also. Okay, so now we'll talk about how to manage unstable angina or NSTEMI. Okay, now the management for both of them goes similar. What do we do is, in both of them, that we have to load the patient with heparin, that is anticoagulant. In case the patient has heparin induced thrombocytosis, that is HIT, we can use bivalirudin. Heparin sensitivity is there, and an antiplatelet drug. Okay, these two are must and most important drugs in the management of NSTEMI. Okay, in these cases in NSTEMI we do not use a fibrinolytic drug because the clot which has formed is rich in platelets and clotting factors, but it is not so rich in fibrinogen, so we do not use antifibrinolytic drug in management of NSTEMI. Okay, which is a main antifibrinolytic drug is a main drug used in STEMI patients. Okay, here the main treatment is heparin or bivalirudin plus antiplatelet drug. So what antiplatelet drug? Antiplatelet drug, aspirin will be used 325 mg plus P2Y12 inhibitors like ticagrelor, prasugrel and clopidogrel. Nowadays we use mainly ticagrelor or prasugrel. The clopidogrel is not used these days. Okay, so I have mentioned ticagrelor and prasugrel up and clopidogrel down because ticagrelor is the main drug. Also prasugrel can be used along with aspirin. Okay, so this is the main management. Now there are some other drugs which will also be used. Okay, we use nitrates, which is a vasodilator. Okay, and beta blockers if there is no heart failure. Beta blockers are contraindicated in case of heart failure. Beta blockers reduce the work of myocardium and hence used in NSTEMI or unstable angina. We can give oxygen if the SpO2 is less than 90%. Also, since there is a plaque, we have to reduce cholesterol, so we give statins also. Okay, these are add-on drugs. Main drug are heparin plus an antiplatelet drug. Okay, now what happens if even after all this, even after we have given heparin, antiplatelet drug and all the other drugs I have mentioned now, what happens still the patient is hemodynamically unstable, that is the patient is collapsing, BP is going down, or there is a refractory pain, that is refractory angina, then in these cases we have to take the patient immediately to the cath lab and do a PCI. Okay, PCI is percutaneous coronary intervention within 2 hours. Okay, if the patient is hemodynamically unstable or refractory angina, or it can be that there are some scores called TIMI and GRACE scores. Google, not so important from exam point of view. So if the TIMI score is greater than or equal to 3 and GRACE score is greater than or equal to 40 after calculating, then also we have to take the patient to cath lab, but within 24 hours. Best is we take the patient within 12 hours, but it is okay if we take within 24 hours. Now it's not like that we have given these drugs and we'll send patient home if there is patient is hemodynamically stable and there is the angina is gone and the scores are okay. Even then, if the patient is all okay, we have to take the remaining patients to the cath lab in less than 48 hours. Best is to take within 24 hours, but it will work if we take with up to 48 hours. So all the patients has to go PCI even in case of STEMI. Not talking about STEMI, that is ST elevated myocardial infarction. There is ST segment elevation in the ECG in ST elevated myocardial infarction. Why there is ST segment elevation? Okay, because there is transmural infarction present in cases of ST elevated myocardial infarction. I told you there is complete occlusion of blood vessel in STEMI, and thereby it will lead to a transmural infarction, and that's the reason of ST segment elevation in ECG in cases of ST elevated myocardial infarction. So now once a patient gets MI and we see in ECG that it is a ST elevated myocardial infarction, what's the management we have to do? So the management will start with, like, the patient arrest is okay. Now the main management is that we have to give the aspirin 325 mm hg ticagrelol, and see here we have mentioned morphine. We did not talk about morphine in the cases of unstable angina. Why? Because we saw if the patient was not okay with the above drugs in unstable angina, the drugs I have mentioned, and if there is refractory angina, which could be masked by giving morphine, because morphine decreases the concept of using morphine in unstable angina is slowly going. Cases of refractory angina in unstable angina, we have to take in unstable angina or in STEMI, we have to take the patient to cath lab immediately. So morphine was not used in unstable angina, but here we use morphine to decrease the pain. Okay, now if SpO2 is less than 90%, we can give nitrates if there is no inferior wall MI, because by in inferior wall MI the patient can be in shock. Okay, that's why, so we do not give a nitrates, which is a vasodilator, and it will further reduce the BP. So nitrates will not be given in inferior wall MI. How will I know that the patient has inferior wall MI? This is from ECG. In ECG, if there, in lead 2-3 AVF there is ST elevation, that's the inferior wall MI. In such cases will not give nitrates. Okay, now we can give beta blockers oral to reduce the work of heart. Similarly statins for the same reasons, and heparin. Okay, now these drugs we have to give, but what's the main treatment in case of ST elevated MI is that the patient has to undergo a thrombolytic or a primary PCI. Primary PCI means PCI after STEMI. Okay, but even if both options are available, the default treatment is primary PCI if the PCI can be done within 2 hours. But if the anticipated time to do PCI is more than 2 hours, then we'll go for thrombolytics. Okay, if we decide that the PCI cannot be done in more than 2 hours, then we have to give thrombolysis, and the door to needle time should be less than 30 minutes. Which means since we have decided that the PCI cannot be done, then the thrombolytics should be administered within 30 minutes of the patient coming to the hospital. Okay, that is called door to needle time in case of thrombolytics use. Okay, but the default treatment is primary PCI if it can be done in 2 hours. In these cases, once we decide that we have to do PCI, then the door to balloon time, that is door to doing PCI time, should be less than 90 minutes. Okay, this is called door to balloon time. Okay, these are very important timelines and we have to remember it. Okay, now we'll take another look at the management of a STEMI patient by a flow chart, by understanding a flow chart from Harrison. So when a STEMI patient who is a candidate for reperfusion comes to a hospital, so he can either be seen first at a PCI capable hospital, okay, or a non-PCI capable hospital. If he is seen at a PCI capable hospital, the PCI capable hospital becomes the first medical contact, that is FMC. The FMC stands for first medical contact. Okay, now when he is seen at a PCI capable hospital, all the patient of MI STEMI should be sent to cath lab. Okay, cath lab is a lab where there is facilities for primary PCI. Okay, once we decide that we are going to do the primary PCI, the first medical contact, that is when patient comes to the PCI capable hospital, and the device time, that is when we do the PCI, should be less than 90 minutes. I told you this is called as the door to balloon time. Door is hospital, the balloon is the PCI procedure. In other words, we can call it first medical contact to device time should be less than 90 minutes. Now what happens if a patient shows at non-PCI capable hospital? There are no PCI facilities available in this hospital, and now this hospital becomes the first medical contact of the patient. Okay, now if that PCI or primary PCI is the default treatment and is a better treatment for STEMI as compared to thrombolysis or fibrinolytic, okay, so we can think of transferring the patient who has come at a non-PCI capable hospital to a PCI capable hospital. This should only be done if the first medical contact to the device time is less than 120 minutes, that is less than 2 hours. Okay, if the anticipated FMC time is more than 120 minutes, then we cannot transfer the patient to a PCI capable hospital. We administer the patient with a fibrinolytic drug like streptokinase within 30 minutes. Okay, this is called as door to needle time. Once the patient receives a fibrinolytic agent, we check whether the reperfusion is okay or there is failed reperfusion, or if there is reocclusion. If there is a failed reperfusion or there is a reocclusion, then we have to urgently transfer the patient to a PCI capable hospital. In such situations, this is known as rescue PCI. Okay, so what is rescue PCI? After giving fibrinolytic therapy, if there is a failed reperfusion, then we have to transfer the patient urgently to a PCI capable hospital. This is known as rescue PCI. But what if the fibrinolytic therapy was successful? There is reperfusion. In such cases also, we have to transfer the patient for angiography and revascularization within 3 to 24 hours. And in such cases, the PCI is known as facilitated PCI. So once the patient is inside a cath lab, I told you here, or in these cases in rescue PCI or facilitated PCI, inside a cath lab, a diagnostic angiogram is done, followed by immediately a PCI is done. These days, there is no role of CABG in management of STEMI. Okay, the PCI is the most important treatment and is the default treatment if it can be done within 2 hours. So this is all about STEMI management, and also all about ischemic heart disease and all the spectrum. So thank you. I hope you like it.